Sounds good. We're on a timer.
No, just because, like, I don't want to get in trouble. Like, I got in trouble yesterday, so.
Looking for Bay.
So
Yeah, they've got it. Oh, I They're confused as to why I hate it. Oh, no.
Okay. I'm going to say please welcome Bay. Or after you drop that, I'm going to say. I'm going to include the starting, so I'm just going to reword it a bit. Just the word for it, please listen.
Okay, everyone, if we can have your attention, we're going to introduce our next speaker. Our next speaker, Danielle Cousineau. Earlier this month, the Minister of Health commented that she was very incredibly moved by the InSite supervised injection site in Vancouver. Our next speaker, Danielle Cousineau, has worked as a registered nurse over the last 3.5 years at InSite and the attached Onsite location.
She started out as a clinic nurse and now is a clinic coordinator, so we're very grateful to have her in from Vancouver to share with us her experiences.
So here, to announce the actual winner of the debate,
Haha. Welcome, Danielle Cousineau.
I am a lot shorter. Sorry, I'm a bit short. Those mics weren't very well set up. Hi. Thank you for having me today. I'm very excited to be here. That was a fantastic debate to kind of warm me up for my talk, so thank you. I will provide one clarifying note. We are open 18 hours a day, not 6 hours a day. So I wanted to yell at you and say you were right. And this is wrong. We're open 9 a.m. to 3 a.m. now. Stats stuff. I won't get into it. So yes, thank you for having me here today. Just to kind of give you guys a quick overview, I'm not going to go into this like major stats and all the research in the site. I think the debate covered a lot of it really effectively. We have been open since 2013, initially as a research study and now as a more permanent fixture in the community. I'm very excited to get to say today that we're one of 2 legal supervised injection sites in North America now, because just 2 weeks ago, the Dr. Peters Center got an exemption application approved by the federal government, which is so fantastic. It's a really, really wonderful positive move for our federal government. It's a really fresh political climate for us, and so very exciting time to be talking about supervised injection in Canada. And then, yeah, along with that, a week ago we had Jane Philippois, our federal Minister of Health, visit us and openly support us. So very exciting times. A little bit more about InSite. We do have 18,000 registered participants who access the site. It's a huge volume of people. We see about 600 to 800 injections per day. We are the busiest injection site in the world based on those stats. And I've got a bit more update information. We have had over 1,500 overdoses at InSite with no fatalities. So again, a huge success. We are showing that we are saving lives and making a huge impact. So instead of spewing stats at you guys today, I want to talk to you about harm reduction. A lot of people, when I could ask you guys today, what is harm reduction? A lot of people will say, oh, it's a needle exchange providing clean supplies. That's where most people's minds go to with harm reduction. But it's a much wider concept, and so I want to talk to you about how InSite implements harm reduction on a much wider scale. One of the first things I want to talk about is the take-home Narcan program. So naloxone, as many of you probably know, is under review by the federal government to reschedule it to increase access to it as a life-saving drug in opiate overdoses. So InSite's involved in a take-home Narcan program where our nurses have the privilege of getting to train our participants who are accessing the site to use their illicit substances on basic CPR, how to identify and intervene in overdoses, and administer naloxone. It's been a really amazing positive impact on the community and empowering them to respond. Because as it was so eloquently put in the debate, not every injection in somebody's day is going to be made at InSite. we aren't open 24 hours a day. Someone's not going to wake up at 6 in the morning feeling sick and decide, you know what, I'm going to wait another 3 hours till InSite opens. I can put up with being in active withdrawal for another 3 hours. They're probably going to use. The other reality is we do occasionally have wait lists. We have waits of half an hour, 45 minutes, an hour and a half, and sometimes people are too sick to actually wait to come into InSite to inject. So it's our job to not only reduce the harms by having people access our site, but also provide the tools so they can be safer in their use when they're outside the site. And that's a huge component of the Take-Home Narcan program. Staff at our site often respond to overdoses that happen in the community outside of InSite, as well as the ones that happen at the site. And so over the past 3.5 years, there's been a huge shift in what we're seeing when we're responding outside of InSite to overdoses. Typically, we've seen a reduction in them because more of the people are actually using at InSite, so less overdoses are happening in the community. But the really positive thing, I personally, when I've responded to overdoses throughout my 3.5 years, you usually show up, the person's extremely cyanotic, they may not be breathing, and we don't know how long that person's been down for, and you're having to intervene, manage that airway, administer naloxone, and call 911. These days, in the last year, there's been a huge shift. When I respond to an overdose off-site now, I often arrive and someone's already giving rescue breaths to that person. The reason people die from opiate overdoses is because they stop breathing or they're not breathing effectively enough, and so their body's deprived of oxygen. So that's a huge intervention that I'm arriving now, and instead of having to start from scratch, start from square one, that person's already getting those rescue breaths. Half the time as well, people have already given a dose of Narcan. So it's made my life a lot easier when I'm responding in the community because I show up and half my job's already done for me. My next step is I can transfer care to myself. I can do more complex airway management and continue to support that person who's in an active overdose while we wait for help to arrive. It's improved people's outcomes, reduced overdose fatalities, reduced disability from overdose. And so, again, harm reduction is so much more than that. We need to provide safety no matter where people are using. So my next concept here in terms of harm reduction, we talk about education. Education is a huge component of harm reduction, and everyone who works at InSite is an educator. We're there to provide information for people, to help people make better informed decisions about their use. It was brought up that supervised injection sites don't allow access to pregnant women, to people who are intoxicated. I feel privileged to say that InSite doesn't fit into that category. We have pregnant women who access our site. If someone comes into our site who's already intoxicated, we're not going to turn them away because we recognize that the risk of turning that person away is greater than the risk to us having them use in our facility. And so we recognize that for that pregnant woman who comes into our site, if we show judgment and stigmatize her for wanting to inject drugs while she's pregnant, that's what she faces in her community. Other drug users will marginalize her and discriminate against her because she's choosing to use drugs. And if we further perpetuate that, she's going to be using alone. She's going to be maybe not accessing clean supplies. And so what we need to do is we need to welcome her into a healthcare facility. We provide education on how to be safer in her use. We make sure she's connected to prenatal care. There's low barrier outreach prenatal care in our community that we're able to connect people with. And so by building that relationship, we're able to build those connections so that, yes, that woman may still be injecting substances at this point in time, but maybe once she's 4 months pregnant, 6 months pregnant, we've reached the point of conversation where we're getting her into a detox, and she's feeling comfortable engaging with our staff at the injection site. And so it's a constant moral battle for a lot of our staff because thinking of a pregnant woman accessing an injection site and injecting crystal meth, it makes us uncomfortable. We're all human. We're going to have that reaction. But it's not our job to judge these people who've chosen to inject substances. It's our job to help these people access care. It's a really great example of client-centered care. I know we all love our nursing theories and we all talk about client-centered care, but it is really important. It applies to that pregnant woman. It applies to, someone comes in and I see they've got a newly formed abscess on their arm. My nurse brain's going off and the alarm's going, oh my God, I need to get antibiotics for that. I need to help fix that. But that's that traditional healthcare model, that top-down model where, as the healthcare provider, I get to dictate what's best for you. At InSite, we function under a much different model where we are there to empower the individuals. And so if that person comes and they've got this skin infection, instead of me saying to them, okay, you need to go to a clinic and get some antibiotics, instead I say, hey, how are you doing today? What's going on with you? And maybe that person's answer is, you know what, I've been up for 36 hours, I'm exhausted, I have to keep using crystal meth to stay awake because I don't have a safe place to sleep tonight. That little abscess that's starting to form isn't a priority. Like, how would you feel if you hadn't slept for 36 hours? Because if you fall asleep on the street, you're gonna lose every possession that you have. That skin infection is just not important. So instead of me taking that top-down approach, you look at that person, you say, okay, what can we do for you? Let's fill out a housing application. Let's call some shelters to get you a bed at least for tonight. In the meantime, can I set you up in the chill lounge, get you a cup of juice, set you up in a corner, and you can just have a nap in our chill lounge. People can hang out there as long as they want. We have people who stay in our chill lounge for 10 hours. And that's fine. We're a safe space for people, and we want to enable people to access us. So with that person who hasn't slept for 36 hours, we show them that they're welcome, and we show that we prioritize their needs. The next day, that person's well rested from that shelter bed we helped them get. Then they approach me and they say, hey, thanks so much for your help yesterday. By the way, I noticed it's starting to get painful in this spot, and it's turning red. What do you think this is? What can we do? And so once we take care of that first need, that need that's identified by that participant, we're able to then reach the point where that person can address that healthcare need that would otherwise be neglected if they continue to sleep on the streets or not sleep on the streets. Another great example that's more of a gradual progression through education is a participant who holds a special place in my heart, who has had 109 overdoses at InSite. A lot of overdoses. He's very well known by all of our staff, and his overdoses are very unique as well. I'm going to get a little into drug actions here, so bear with me. This individual, he's a 70-year-old man. He's been using for 40 years, injecting his drugs. He has used up all his venous access. He has absolutely nowhere that he can inject intravenously. He also illicitly uses benzodiazepines, CNS depressants. So before he comes into the site on a typical day, he'll take a few benzos orally. Nice slow release with an oral intake of a benzodiazepine, and then he comes into our site and he can't inject intravenously anymore, so he injects into his muscle. And so he injects his heroin into his muscle. So he's in our injection room, he's alert, he's awake, he's interacting with staff for a good 10-15 minutes. Then he goes to the chill, gets his coffee, and this is where that key bit about having that space for people to hang out that's really safe becomes really important. Because it's about 20 minutes after he's injected in our injection room that we're getting the call from our peer staff who run the chill lounge saying, he's down again, bring the crash kit, and we're running into the other space to go intervene. It's a delicate balance because our nursing staff, we have to stay in the injection room, but whenever this particular participant comes through, all of us are like, okay, we're in ready mode to go intervene in this, but he's had thousands of visits, so it's maybe 10% of his visits where he's had these overdoses. So it's not like we're going to stalk him into the chill lounge every time he uses. It's not an effective use of our time. So that's how we rely on our staffing team. It's very important. So the happy side of this story is it was about a year and a half ago when he reached really a personal crisis in his overdoses. And what I mean by that is he was overdosing at least a couple times a week. And it was becoming quite an issue that our staff identified. And this is where, yes, we're there to intervene in an overdose, but that overdose intervention is more than airway management. It's more than administering naloxone. It's a point of contact. And so with each and every one of those overdoses, our staff were engaging with him and then talking to him about, okay, what do you think triggered your overdose today? Did you have your benzos before you came in today? Is this your 4th injection of heroin today? Did you change your dealers? And we talked about it a lot. People who come in are using illicit substances. And our illicit drug use supply is becoming so unreliable with the fentanyl getting into all of the drug supply. It's really, really hard to know what the potency of drugs are. We can't test them. We don't know if it's pure fentanyl or if it's absolute crap with no opiate in it at all. And so people vary their doses because one time they do a flap and they don't feel high. The next time they're like, okay, I'm going to do 2, but then it's fentanyl, and so they overdose. And so with him, every time we interacted with him after his overdose, what happened? What triggered this? We'd have that discussion with him. And it's really promising to get to say that he's actually reduced his rate of overdose. And so in the last 6 months, I think he's had maybe 4 overdoses. And so that's one of the things where harm reduction, it's not a sudden change. It's really small incremental changes that we have to celebrate. If I did this work and my goal is I'm gonna help someone get to detox, turn their life around, and they're gonna come back and become like a leader of an NA group, my job would be miserable for me. I celebrate the small successes, the small incremental changes, and that small impact actually has a huge impact with that individual. We're empowering that participant to make the decisions around how much he's using. We're empowering him with knowledge so that he can be safer in his use, without judgment, so that he feels safer in the space. And if he makes that decision for himself one day that he decides he doesn't want to use anymore, he knows that we'll be there and we'll support him in that decision as well. So just really important to say, and this applies to any area of healthcare you work in, we're all human. Change sucks. We all hate it. Be patient with people. It's those small things, and you really do need to celebrate them. Another really wonderful example of harm reduction education is when we do booth assistance. It was brought up in the debate that certain people with disabilities and that we're enabling drug use because people are going to come and we can provide assistance to them. A really wonderful example of this is a young transgendered woman who has cerebral palsy who accesses our site. Now, when someone comes into our site with bad rheumatoid arthritis or cerebral palsy and their hands are just in such a position that you're like, I don't know how that person's going to physically hold a needle, let alone aspirate to check placement, push that plunger down to inject a substance. The really amazing thing is when you provide information to somebody, and this person had initiated their use on their own, but the issue is a lot of people who are in that kind of situation where they maybe don't have that really good dexterity is they initiate their use by getting injected by other people, whether that's a boyfriend, a girlfriend, a dealer, their neighbor. A lot of the time somebody else initiates that injection drug use for them. And so does that make them have any less of a right to access life-saving services and education on how to be safer? There's a lot of research around what the risk of injection drug use is when you don't inject yourself. When you don't inject yourself, you're at increased risk of contracting HIV or Hep C because you've lost control of that process. That person who's injecting you could be using equipment they've used on somebody else multiple times. You don't know where that equipment came from. There's a risk you're going to be injected with something that's unknown or not what you intended to inject, because again, that other person has taken over that process for you. You're at risk for OD. If I'm an opiate user and I'm injecting myself with what I think is heroin, turns out to be pure fentanyl, I'm injecting into my vein, I start to nod and start to gently OD, I'm not going to finish that injection because I'm going to fall asleep. So I might have a mild overdose, or I just might be in what we call the nodding phase, where I'm still breathing, but I'm not fully roused. If somebody else is doing that injection for me and I start to nod out, that person's probably going to finish that injection, and it's going to be a much more severe overdose. So that loss of control is huge. Other things that often happen when somebody else injects for you, you get sexually assaulted, physically assaulted, robbed. So when someone comes to us and they've been getting injected by somebody else, they have a physical disability, it's our role to help empower that person to be independent in their injection. Because this goes back to, again, we need to reduce harms of people using while they're at our site as well as outside the site. And so what was really amazing, and our staff have really kind of risen up to the occasion, is it's been, again, small incremental changes, but she relied on us a little bit more heavily than we would have liked when she first came in. But through small bits of education every time we interacted with her, she's now like 99% independent in her injection practice. So we can know that she's going to be safer when she chooses to inject outside of our site, because we are now reducing her risk of HIV, hepatitis C, overdose, sexual assault, physical assault. Now, this concept of teaching someone to inject independently might be causing some of your stomachs to turn a little and make you a little bit uncomfortable. Morally, supervised injection is a very uncomfortable topic, and I really recognize that. And I really want to state that, the staff that work at InSite, we have those same gut reactions. We have those same reactions, just that clenching of that stomach when you know this doesn't feel good. But you have to reground that. You have to reflect on, that's my values that I bring to this based on my background. And it's a constitutional right. That's what the Supreme Court of Canada ruled, to access this kind of service. And so it's not my place to judge. These people who are accessing this service, they have a lot of different reasons that they're accessing it. A lot of them severely marginalized, generations of poverty, history of residential school. Can we really judge someone who wants to medicate that pain and that trauma that they've come through? Some people are actually self-medicating for mental illness. There's one individual that I know who his parole officer is actually encouraging him to use crystal meth right now, because he is the most functional he's ever been in the 10 years that she's known him, because it's controlling his ADD better than any medication he's ever been on. Sounds a bit backwards, I know, but he's actually becoming more stable in his life through his crystal meth use. Sounds backwards as I say it. And so that self-medication, and a lot of people, you're using to feel normal. You're using so that you can feel like you can have interactions with other people, so that you can function on a day-to-day basis. And everyone has a right to that. And there's no reason that I can think of that we could possibly take that right away. Another really big thing that we advocate for at InSite is that healthcare is always changing and evolving. The needs of the people we're working with are always changing and evolving. And at InSite, we're really wonderfully situated to always evolve and always change. We've got a really unique staffing group where we've got nurses, we've got support workers who come from a really diverse range of backgrounds, from personal addiction to living in poverty and bringing that personal experience, and then we have peers. And so it generates a really healthy dialogue around what care we're delivering and what care we should be delivering. And we opened initially under the model of that traditional harm reduction is going to be to give people needles and to intervene if there's an overdose. As I've said to you in a few of these examples, harm reduction is so much more than that. And so we've expanded our services. We're doing the take-home Narcan. We're doing complex wound care management now for people. We're doing some primary care for people, managing STI infections, gonorrhea, chlamydia. A lot of the people we see are working in the survival sex trade, and so are at higher risk of having sexually transmitted infections. But if you think about a woman who's maybe working in the survival sex trade, she's been out all night, she's been working to earn the money in order to get enough money to score her next hit. She finally gets it, she comes to InSite. She's feeling sick, she's waiting in the waiting room. Her name gets called, she gets to go into one of our booths in this lovely photo. And it takes her an hour to find a vein and successfully inject her heroin. And then she finally feels well. For the first time in 6 hours, she feels well, she feels normal. She feels like she can function again. She maybe spends another half an hour in that safe space, just in that feeling of, okay, I am who I want to be right now. Like, I feel like I can function. She gets up, she walks out that front door. What goes through her mind? I gotta go back to work. I don't know how long it's gonna take me to earn the money that I need to get my next score. Is it gonna be an hour? Is it gonna be 8? Am I gonna be in withdrawal by the time I get enough money to use again? And that's what feeds into some of this addiction. And you know, people talk about the drugs and the drugs being this really horrible thing. It's actually the lifestyle that goes along with the drug use that causes the most harms. It's the fact that that woman, when she walks out the door, instead of thinking, okay, I'm gonna go have dinner now, or I'm gonna go lie down and get some sleep now, it goes back into that cycle of, okay, I need to figure out how to get that money so that I can continue to feel well. And so it's that lack of nutrition, that lack of sleep, all those, and then that disconnect from your social connections, because I'm not going to think, oh, great, I just used heroin, now I'm going to call my mom and see how she's doing. That's not the way it works. And so I'm going to kind of segue into, has anyone here heard of Salome or Crosstown Clinic? Hands, anybody? Yeah, I see like 2 hands. Woo, 3 hands, yeah. So I'm going to briefly talk about it because it is an interesting alternative perspective that I think is really important in the spectrum of harm reduction. And what they are is they were a research study called Salome, and now they're actually a permanent site called Crosstown Clinic. And they're the only place in Canada that's providing prescription heroin to people who are severely entrenched in addiction. So what does that look like? So it's people who have failed multiple times on traditional oral replacement therapy, such as methadose or Suboxone. And in this study, so they've got their own, they aren't really an injection site. They do have their own injection room. And basically, they import pharmaceutical-grade heroin from a pharmacy in Europe. Customs nightmare, I'll just say that, throw it out there. Every so often they get cut off from their supply, unfortunately. But they're prescribing heroin that's a known purity at no cost to these individuals. So let's go back to that story about that woman who's working in the survival sex trade and working herself into the ground in order to get the money to feed that habit. If she gets into that program at Crosstown, she goes in, she uses, she feels well, she walks out that front door. She knows her next appointment's in 6 hours for her next injection of heroin that she pays nothing for. What does that do for that woman? She can walk out that door and go, I wonder if I can work on getting some better housing. I have a bed bug issue in my building, and you know what? I'd feel a lot safer and more comfortable at home if I could get into a better place. And she can put that energy towards working on housing. Or, you know what? I think I want to change my method of employment. So I'm going to pursue some of the peer programs that are happening, and I'm going to see if I can start making money through working in groups or working at InSite as a peer. So that reframing and that taking away that constant need for somebody to commit some kind of crime, often, whether it's theft, under our current legislation, survival sex trade. I mean, I know it technically doesn't criminalize the woman, but if you criminalize the John, you're still pushing that woman into a corner of society. That's a whole different issue that I won't dive into, though. And so, if any of you are interested, I really encourage you to look into the Salome Project, because it's a cutting-edge harm reduction model that I really do hope gets the opportunity, similar to supervised injection, to expand throughout Canada, because it's shown huge benefits for individuals. And I know a number of people who had been accessing InSite since the day we opened, who accessed this program and now have good housing, are working full-time at InSite or at other projects, and look back and just kind of say, like, wow, I don't know how I did it, but this is amazing, and it provides that opportunity. You know, a lot of society has the perspective that addiction's a choice, drug use is a choice. And you know what, that woman who's working the sex trade to feed her habit, she should just choose to stop using. I think we can safely say that we all know that's not a reality. It's a much more complicated situation than that, and I think we need to give credit and we need to provide opportunity. I'm not saying that prescription heroin is for absolutely everyone who ever tries heroin. That's not realistic or appropriate by any means. But harm reduction is a spectrum. We need to meet people where they're at to provide the service that is going to best fit their needs. And really what that means is just coming with no judgment, preserving people's dignity and empowering them. The debate briefly touched on our success rate at getting people into detox and then longer term treatment. That's a really interesting concept at InSite. I don't know how many of you know, but so I work in a 3-story building. The main floor is the injection site. The second floor is an inpatient detox facility. And the third floor is transitional housing. Who would have ever guessed that having a detox, the floor above an injection site where people come to use their illicit substances, would actually work? But it is. We get the odd noise complaint at 3 in the morning when we're playing our music too loud in the injection site. But it really is working. And what's really amazing about it is you would think that it would inhibit people accessing one of our services, because we're doing that intake. Basically, someone comes into this injection room, they use, and then they come up to a staff member, they're like, you know what, I really need a break, I need to get into detox. And we're like, great, let's get you upstairs. It doesn't happen that way every time, but sometimes it does. And we're bringing that person straight from that booth in that injection room into a detox. We all know addiction's a cycle. Relapse is a very normal part of that cycle. So what happens when that person finishes their 2 weeks upstairs, goes to the transitional housing, has a slip, relapses, and has to leave that transitional housing? They're going to continue injecting in their relapse, but we need to make sure they feel safe re-engaging at that base level of healthcare. All of us, I think, can admit that when we set a goal for ourselves, we work toward it, and then if we fail to achieve that goal or we slip back in that goal, we feel shame and we feel guilt. And it's really hard to admit to our support system that we failed at that. You want to hide it from them. That's counterproductive for us. We don't want people not feeling safe accessing the injection site. Because then we wouldn't have anyone to access the injection site if everyone who went into the detox never came back. And so it may sound like really small gestures, but our staff work really hard to, every time someone walks through the door, we have a genuine smile on our face, and we're genuinely happy to see that person. Ask them how they're doing, what's going on with them, and that person might express to us, hey, you know what, this is going to be my first use after being abstinent for 3 months, and I feel like shit, and I might overdose, and I'm scared. And the fact that that person, because our staff approach working with our participants in such a non-judgmental, low-barrier way, that person can say that to us, and we say, hey, thank you for telling us that. We'll keep an eye on you. Can we do anything for you? Are you sure about this decision? Because we can help you tie into other services if you need to. If the person says, no, I know I'm going to do this, I just need to do it now, we'll let that person access. A really interesting other element, we're currently doing a pilot study at InSite that might seem a bit harebrained and crazy, but we're actually prescribing methadone and Suboxone essentially in our injection room to our participants. It's a little bit strange. Who would ever think that, someone comes in with their illicit substance, they inject, and then they walk 10 steps to the side, and we got a doctor there, and we're going to prescribe them methadone. It's a little bit weird, a little bit awkward. We're still working through some of the kinks of it. But it's been a really amazing experience of modeling low barrier access to care. And, you know, there's been struggles sometimes when it's like our people who are accessing the clinic are still accessing the injection room. We're seeing that they're reducing their use as we're increasing their methadone, but then that person has an overdose. And just the other day, our nurse who runs the clinic came to me and she just is like, I don't know what to do. Like, this participant who's in our program had a stage 3 overdose. That's the most severe overdose. The person stopped breathing. We have to insert an airway breathe for them, give them Narcan. It's a really severe overdose. And this person's been working up on their methadone dose for like 6 weeks now. They're getting to be at quite a high dose, and their risk of overdose is significantly increasing. The nurse is just like, do I talk to him and identify the fact that I am accessing this information because I work here? Or is that going to compromise our relationship, and is he not going to feel safe coming to us anymore to access replacement therapy? It took a lot of work for us to work through why we were feeling that way. We hadn't talked to the participant yet about it, but we felt really uncomfortable about it. But it actually opened the door to a really great discussion. We were able to sit down with the person and just say, hey, you realize I work here, you realize I've got access to this information. I'm not going to judge you for this. I'm just really worried about you because you had a severe overdose and we're going to keep increasing your methadone. And so your risk of that overdose is just going to keep going up and up and up. And so I want to talk to you to make sure you understand what's going on to try and reduce that risk of overdose. And it was actually a really positive interaction, which kind of surprised us because we were a bit worried that we were going to set ourselves up that he was going to stop accessing InSite for his injection purposes and start using an Alley's or alone in his room. And so it's allowing us to have really open conversations, whereas if that person was maybe going to a clinic down the street, they might not feel safe identifying the fact that they're still injecting their drugs. And so, huge learning process, but it's really refreshing to get to keep feeding into that changing healthcare system and try new things and make mistakes. Mistakes happen, but if we don't feel uncomfortable and if we don't make mistakes, we're never going to improve our healthcare system. We're never going to improve the care that we're providing to people. So, I mean, the moral of the story here is that harm reduction is a diverse spectrum of interventions. I haven't said it directly, but I really hope that you guys grasp the fact that harm reduction can and should be integrated into all nursing practice. It always surprises me when I ask someone what's harm reduction, and they're like, yeah, it's giving out needles. It's not. We do harm reduction every day. We put our seatbelts on when we're in a car. We put our helmet on when we get on our bicycle. Providing a sandwich to somebody who is living in active addiction is harm reduction because you're providing nutrition to that person. If you're working in pediatrics, you can enact harm reduction in your practice. So I really hope that you guys kind of grasp that and bring it into your practice and become more open to it. Because, I mean, the term makes some people uncomfortable. It seems like a really politically charged term, and it's kind of crazy that we still have to debate that harm reduction is a good intervention with all the research that's out there. But I think if we, as future nurses, you guys in the room, if you start integrating this into your practice every day, in no matter what area you work with, no matter what population you work with, we're going to decrease that stigma towards harm reduction. We're going to decrease that resistance towards harm reduction. And in turn, reduce resistance to treating everyone like a human being with dignity and respect and providing them the opportunity to be safe as a person and respected as a person. So that's all I got for you. If you guys have questions, I would love to hear some. We've got 2 microphones. Or, yeah, go ahead.
So obviously the therapeutic relationship and therapeutic communication is a huge part of the success of your programs.
Mm-hmm.
So what kind of training do the nurses get in addition, like, you know, some sensitivity training and communication training in that program?
Great question. For people that didn't hear in the back, the question was about therapeutic relationships are really important to the care we provide, and what kind of training do we provide to our nurses to help support them in this work. And so, unfortunately, not much. In our debate, it talked about we're spending too much on supervised injection. Our budget's like $3 million a year. It's a very small drop in the bucket compared to all the money. But in terms of education, a lot of it is actually, we expect people to come with that self-reflection, and that people need to be working in the context of understanding their own morals, their own values. So a lot of the nurses that we typically hire have experience working in the area of addictions or mental health with marginalized populations, so they can bring that perspective, and then we work on teaching more of the skills around the emergency interventions and the more task-oriented stuff. Yeah, unfortunately, we just don't have the funding to provide that kind of education. Question in the back. Mm-hmm. Yeah, so some elaboration has been, she's asked for some elaboration on what we do in terms of assistance. So we do have some very strict guidelines. We cannot doctor people, as most people call it. So I can't physically inject for somebody. That would be illegal. And that would be against my nursing practice, because I don't know what I would be injecting into that person. So a lot of what we do is education. I wish I had brought supplies, but the airport doesn't like it when you come through the customs with cookers and needles and that kind of stuff. So I figured I'd rather travel safe. Basically, what we do is a lot of verbal direction and demonstration for people. And so the majority of what we do is basically, if I'm in a booth with somebody, they'll have their set of equipment, and then I'll have my own set of equipment so that I can show them, okay, add about this much water, this is how we're going to cook it, this is how you use the filter, and then demonstrating on myself and having that person practice it back to me. And that's been shown to be the most successful way to help empower people in their use. That being said, there is occasion, for example, the young woman with cerebral palsy. Because of her dexterity, she can do almost everything. The one thing she has trouble with, I'm going to use a red pen to demonstrate, is it takes a lot of dexterity to put a needle and then be able to aspirate that needle and push the plunger down. And she doesn't have that capability to put that needle in. So she puts that needle in, and then we will hold it for her while she repositions her hand to a place where she can pull that plunger back, and then we'll move our hand away and she can pull the plunger and push it down. So we'll provide some assistance when someone needs to maybe adjust a hand grip in that, but beyond that, people are having to function independently in their injection. Yeah?
Seems to be very counterintuitive type of care. And from what I understand, there are moral dilemmas on a daily basis within your practice. How do you come to address the public at large and media's concerns? Because it's such a complex issue, and you had so many stories to explain us in detail. How can we get this message around when it's such a sensitive topic, and people are so concerned about ideology and Canadian values and this backward way of doing things?
Yeah, and it has been a constant battle for us on the moral argument side. I don't know if many of you are knowledgeable about the court case that the previous federal government took against InSite, but basically the former federal government was fighting to close InSite down based on moral arguments exclusively. And while it escalated through provincial courts and eventually to the Supreme Court of Canada, the legal team defending InSite literally had a stack of research studies. This is all the evidence that shows it's an effective intervention. And the lawyers for the federal government had to stand up, and the Supreme Court judges asked them, okay, so we've heard the evidence from the team of nurses in favor of, team of lawyers in favor of InSite, what evidence do you have that shows it has a negative impact? And the federal government lawyers had to stand there and go, none. They had no research. There was one study that was funded through the RCMP in Vancouver that was later shown to actually be false, and it was actually falsely manufactured research against InSite. And so, sorry to the negative side of the debate team, you guys didn't have a lot of evidence. But it's just not there. But in terms of on the moral argument side, a lot of it is public education. And it's becoming more and more important as the neighborhood becomes more gentrified. We're going to have new neighbors moving into a new condo building across the street from us next month, I think. That's going to be really interesting because it's not low-income housing. So one of the ways that we really try and do it is through public education, through me talking to you guys here today, through providing tours for any kind of community members that are coming through. But I mean, we're very lucky in Vancouver that we have support of community members, of our local government, provincial government, of the police force. I mean, it's really telling when the site opened and there was a bit of a lack of trust. Like, you guys are really going to give us a space inside where we can come and inject our drugs and you're not going to arrest us for us? Like, I don't know if I'm going to go in there. This is a setup. And the police department, local police department, actually, they would troll the alleys around the neighborhood, and if they came across someone injecting, they'd be like, no, 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 you can't do that. And they'd pick the person up, and that person thought they were being arrested, but the police officer would walk the person to InSite and push them to the front door and say, you're going to use here now. Stop using the alley. So that public buy-in was huge at kind of helping us develop that trust and base in the community. So it's not an easy battle. It's slow, but it works. Yeah.
Why isn't it 24 hours? Why this just straight up money that seems...
Money. Money. It's always about money. No, and I can frame it a little bit for you because as photos of my slides, which are slightly dated, show, we used to be open from 10 a.m. to 4 a.m. And just in November, we adjusted our hours to open and close an hour earlier. The benefit to being opened as if we're a research study is that we have a lot of stats, a lot of wonderful stats. And so we were able to actually look at how long people were spending in booths, how many people were accessing the site from the moment our doors opened until the moment we closed our doors. And so after kind of 11 p.m., we started to see a decrease in the number of people actually coming to access the site, and then it was longer visits, that people were using us more as a sheltering space than an injection space. And then at 10 a.m., we would open, fill our 13 booths, and have a wait list of 10 people. And so that showed us that we weren't effectively meeting the population where they need the service. And so we adjusted our hours so that now, opening at 9 a.m., within 30 seconds of opening, we're maybe half to 3/4 full, and then we gradually build up our fullness through the day so that we aren't having people standing outside our doors half an hour before we open, counting down the seconds until we open our doors. So yeah, it's a juggle of, there isn't the money, but also it isn't a cheap service. It's expensive to pay nurses to run a shelter. But I mean, I'm gonna just plug, there is a debate around applying InSite's model to other communities. And Vancouver Coastal Health recently came out saying that they support more supervised injection in the communities. And it's my perspective, really positive way. Vancouver is a unique situation in terms of our high density population, but we definitely don't have enough supervised injection in Vancouver. Do we need another InSite? It'd be awesome if we could get it, but what's more likely is integrating that service into other services. So we've got a drop-in center for women who work in the survival sex trade. Why not have a 5-booth injection center integrated into that drop-in center? We've got people who already feel safe accessing that space. We know they're injecting in the bathrooms at the drop-in center. Why not provide that space? And that's what the Dr. Peter Center had been doing since 2002, in case you guys aren't familiar with it. They're the second legal supervised injection site. They're a drop-in center and clinic for people living with HIV, and they recognized that people were injecting their bathrooms or outside their front doors, and so they actually created a 5-booth injection site off their clinic so that if someone wanted to use, they could go in there with a nurse and use. So not a full-time functioning injection site, but providing that service integrated into where people are currently accessing services or care, I think would be great. So that's my opinion. I think I have a question at the mic behind you, actually, and then I'll come to you.
Sorry, I just was in the back and I couldn't hear any of you. So I was just wondering, I think I speak on behalf of a lot of people here that are really interested in this kind of role. And I was wondering if you would recommend anything that we can do as students, as volunteers, or any sort of programs that would exist for those of us that would be interested. Because I think we're all hoping that this moves across Canada. A lot of people here are hoping, and I would love to get involved, and I think a lot of people would. So do you recommend anything in that?
Yeah, there's a lot you can do. Wound care, like complex wound care is so fun. All our nurses love it. Like chronic, like cavity wounds, get in there, get messy. That's a fun one, personal favorite, yeah. Any kind of education around culturally competent care. BC's got a provincial education program on that. That's an online course that you can take that's fantastic. I'm not sure about other provinces in Canada. Anything around addictions care, mental illness is huge. We provide a lot of intervention for people living with mental illness, and so being able to do a really good MSC, a really good suicide risk assessment, we use that multiple times per shift. I mean, partially because people are coming with mental illnesses, but they're also using substances that alter their mind. So someone uses cocaine, it lasts maybe 30 minutes, they go into a severe psychosis. We're having to manage that escalated behavior. Someone uses crystal meth, goes into a drug-induced psychosis, it lasts 6 hours. And so some of that stuff's really challenging to manage. So yeah, any education around mental illness, addiction is huge. Because as nurses at InSite, you're information keepers. So people come to you with like the most outrageous questions. Like they'll literally walk up and be like, my doctor prescribed this, I don't know why. And it's like, oh, it's metformin. Okay, you must have diabetes. Do you know what that is? No, okay, let's talk about diabetes. So you really have to be a generalist and kind of know everything. At the same time, it's really important to know what you don't know. And I think that's one of the biggest challenges as a nurse. And you'll experience it when you graduate. Your family members and friends expect you to be an expert in everything. And it's the same way at InSite. You're supposed to know absolutely everything and know your limits. Know where your resources are, where you can seek out that information, because that's what's really going to set you apart, is just that being genuine in who you are and what you know.
Thank you.
No problem. Do other people want to go to the microphone? I feel like that's a nice thing to do for people in the back. They can't hear. Sorry. Thank you.
Hello.
Hi.
I'm wondering about advanced directives, and if you guys ever have people on those.
Good question, because we do have palliative patients come in, interestingly enough. No, we do not have advanced directives, is the short answer, because when people register with the site, it's a fairly short registration process if there's someone who's entrenched in their drug use. And basically in that is by walking through our front doors, you are consenting to all medical care that we deem is necessary. And if someone is unconscious in an overdose, we will intervene. It does get interesting when somebody comes in and they've got 5 grams of heroin and they're sitting there going, I'm going to inject all of this right now and kill myself. And we're kind of like, you could, but it might be a waste because we're just going to Narcan you and you're not actually going to die, but do what you got to do. Sorry, dark humor. But just on a quick side note from that, we actually have another site that I haven't mentioned that's a block and a half away from us that we co-run as well, called the Community Transitional Care Team. And it's a subacute medical unit that's in an SRO. And it's also classified as a hospice. We do end-of-life palliative care there. So it's a really interesting cycle of projects we've got with Injection Site, Detox, and then this medical unit in the community, where we're seeing people cycle through different stages in their health and different stages of their lives. And so often our InSite participants, when they're palliative and receiving end-of-life care for heart failure, they're often staying at our community transitional care team receiving that palliative care. But if something happens that goes wrong, we will intervene and then communicate with our team back there to get them the proper support and follow-up. But, yeah.
Sorry, it's a little, okay, there we go, we're short. Hi, so I'm from Vancouver, and I had the privilege of actually going with my classmates to visit InSite. And we had a couple questions, but I think we never fully asked them all. But I was just wondering, do you have any, do you also work with youth as well, like under 18? Or are they part of a different, like under, a different program or whatsoever?
Yes, that's a very interesting question. The youth debate came up in your guys' debate earlier. So we do have an age limit. Our age limit is 16, and it is a hard line. To answer some of the questions that came up in the debate, if someone under the age of 16 presents and wants to access the service, we are legally obligated to contact the ministry about that person attempting to access service. Youth kind of go along with pregnant women as that morally uncomfortable situation that we're kind of like, this really young person, do we really want them injecting their drugs? We have a specialized process for working with youth at the site in terms of when they first access the site and as they move through our services. We consider a youth anyone who's 16 to 25 years old, and we provide a lot more intensive education and discussion with them before permitting access to make sure that they're making the best informed decision that they can. Thanks. Sorry, I got my time card. And just basically making sure they've got all the information before they make that decision. It's a difficult decision for our staff to make when they have the power to say yes or no to this individual accessing that service. But over the 12 years that we've been open, we've worked out our kinks. It's not put on one staff member. We've got 2 staff members in there at all times working through it, and it's always our senior staff figuring out what's going to be the best decision for that individual. I felt like I rambled on that a bit. So for people in the back who didn't hear that, the question was why we're providing methadone to people who are still using, who we are worried about their risk of overdose. Great question, by the way. So the mechanism and kind of the way that methadone is initiated is typically most people will be started on a dose somewhere between 25 and 35, and it's a very slow tapering up, usually 5 milligrams per week, maybe 10 if they've got a really lenient physician. I can't read that, but okay. Okay. And so for somebody who's maybe using 2 grams of heroin per day, they have a really high tolerance to opiates. And so if you're only giving that person 35 milligrams, that's not really going to compensate for how much they've actually been using. And if that person was just to cut themselves off of their opiate they're using, they would be in really severe withdrawal and they'd be unlikely to actually successfully initiate methadone maintenance. And so what the goal is basically the slow tapering up of methadone happens typically, it might take a month, it might take 2 months to reach a therapeutic dose. Like the individual I was talking about who had the severe overdose is now at 150 milligrams of methadose, and is probably going to keep going up because he has such a high tolerance for opiates. But basically, as that methadone increases, the goal is that that person starts declining their use. And so it's not an expected, like, okay, we give them it and then all that heroin, they're going to stop using it. It's that kind of slow transition that we're looking for. And so it's about having open and honest conversations about people and, you know, have you managed to reduce your risk? And often the person will come in and they're like, yeah, you know what, like, my habit used to cost me $50 a day, and now I'm only spending $20 a day. That's huge, that's progress. And at the same time, opiate replacement therapy, like methadose, everyone has different goals in their recovery. For some people, they want to reduce the amount of use that they have. For some people, they want to be abstinent. And so it's about meeting people where they're at, what their expectations of themselves are, and making sure we tailor care to each individual. Yeah.
I'm going to ask really quick. Could you kind of indicate about other harm reduction sites across the country? I know they're not as extensive as InSite, but.
Thank you. So yeah, I mean, in Vancouver, we now have 2 injection sites. And then harm reduction across Canada, for the most part, is needle exchanges, unfortunately, in relation to injection drug use, or providing crack pipes. There's a really cool program in Vancouver where people can blow their own crystal meth pipes. It's so cool. They have a glass blower come in. Anyways, yeah. And then, I mean, it's exciting about Crosstown Clinic becoming permanent in prescribing heroin. We're definitely lucky in Vancouver that we've got a lot of community drive for harm reduction, so we've been able to act on the cutting edge that way, but we're very excited. Victoria is speaking very publicly to have a site open by end of 2016 for supervised injection. Montreal is looking at 4 sites, so I really think things are changing, which is great. And I think I'm out of time now. Thanks, everybody.